Good evening. We want to welcome you this evening to the Church of God webinar on the topic, the COVID vaccine. We have a very exciting evening plan, and we hope that you will tune in and that you would be well informed. We have this evening a special welcome goes out to Dr. Lynda Williams. We know she's the president of BAMP. She's also an epidemiologist. She's a family practitioner. We welcome Dr. Lynda Williams. We also
Thank
have
you.
with welcome. We also have with us this evening Dr. Renee Boyce. She's also a family practitioner, and she will be our moderator this evening. So we really are so grateful to have both of these ladies here with us this evening to explain to us all about the COVID vaccine and answer some of your questions. Now we also have other churches joining us, and these churches are we are really glad to have them. We have joined us this evening Bishop Selwyn Braffett. He's representing Pawi. We also have Bishop Derek Ward from Harvest Bible Chapel and his congregation. We also welcome Elder Miller. He's from the Dells Road Gospel Hall, and he represents all the Gospel Hall churches here in Barbados. We also have Reverend Oswald Shemet. He's from Western Light Nazarene, and we are also glad to have him and his members here with us this evening. So we have a wonderful time this evening planned for you. And without any further ado, I'm going to turn it over to Dr. Renee Boyce, who is going to be our moderator. So God bless you. And both of these ladies are sisters in the Lord. So more better to this to talk about COVID and to tell you all about COVID and the vaccine that is now in Barbados. God bless you, Dr. Boyce.
Yes, good evening, everybody. Thank you so much for that introduction, Pastor Burrows. We welcome you to this our webinar talking about the COVID-19 vaccine. As you've heard in the introduction, Dr. Lynda Williams is well able to speak on the vaccine. She is an epidemiologist and a family physician, but she's also leading that task force, the COVID task force from BAMP, which has interactions with the Ministry of Health and so on. They've been having a lot to say about the COVID-19 vaccine and the whole COVID-19 pandemic. Just a little bit of housekeeping. We are thankful for those of you who have sent your questions in, and certainly our attempt will be to answer all of the questions. If you realize that your particular question might not have been answered, what we encourage you to do is go back and watch the video, because that might have been answered before. And if during the process of the evening we're unable to get to your specific questions, please certainly leave your questions in the YouTube chat, and we will try our best to get back to those questions before the end of next week. Dr. Williams, thank you so much for joining us. You have a presentation that you want to share with us. So let's go through your presentation, and then we'll address any of the questions which won't have been answered by your presentation.
Good evening, everyone, and thank you for the opportunity to share with you about COVID-19 and the vaccines. For the last maybe 11 months, the BAMP COVID-19 task force, of which I am the co-chair, have done nothing but eat, sleep, and drink COVID-19 because it's such a new and novel disease, and we're just finding out about it as we go along. And so we began to share information among doctors, and this really helped to strengthen our response here in Barbados. So I'm going to share with you a little bit about COVID-19, and just give me a second. Right. And the Oxford Astrazeneca vaccine and its implications in COVID-19. So thanks again for the opportunity to talk about it. And I'm going to start with telling you, first of all, what epidemiology is, because a lot of people ask me that all the time. What is epidemiology? So epidemiology is the study of the spread of diseases. And by studying the spread of diseases, we use mathematics, a lot of maths, to what we call model how diseases would progress. And this is not just for infectious diseases, but also for chronic diseases. But epidemiology began with the study of infectious diseases. How do disease epidemics spread? Hence the name epidemiology. Okay. So just to give a little bit of history on the epidemiology of COVID-19, back in 2019, on December 31st, the local authorities in Wuhan, a city in China, reported that there was a cluster of viral pneumonia of unknown origin among contacts in a human seafood market on December 31st. And they provided this information to the WHO, the World Health Organization, on January 3rd. Now, you may not be aware, but for many years, the WHO has had a pandemic response team. Why is that? That's because we knew that global pandemics were becoming more and more likely as we have more and more people living together and people living in close proximity to animals. The possibility of viral pandemics was increasing. And so for at least the last 30 years, we have been following all the different types of global pandemics. We've had bird flu, we've had Asian flu in the 60s, we had bird flu, we've had Ebola, many different viruses that we have been following. We had SARS, we had MERS. And so once they received this information on January 3rd, they sprung into action. They sprung into action first to identify what is this virus. And they found that it was a COVID-19, was what we call a beta coronavirus, and that it was very similar to SARS, which had broken out in 2003, 2004. And so they designated this virus SARS-CoV-2, Severe Acute Respiratory Syndrome Coronavirus 2. And the first death from this occurred in China on January 11th. And then it spread to outside of China by February 2nd. By February 11th, they had a name for the disease. We called it COVID-19 because of the year in which it was found, okay? And the WHO declared that it wasn't a local epidemic. In other words, it wasn't just affecting China. It wasn't localized in countries around China. It was a global pandemic on March 11th, 2020. Now, why is that significant? Because a global pandemic meant that everyone in every country had an equal opportunity of becoming infected. This is a disease to which we have no known natural immunity. It's new, and therefore it could spread outside of China quickly. And so that's why the declaration of a global pandemic is very important. By now, all countries have reported cases of COVID-19, and the shift from China to Europe and then to the Americas occurred between March and May 2020. So what did we know about it? We knew that it was transmitted by droplet infection. And what does that mean? That means that cough, sneeze, and respiratory activity such as loud singing or propelled voice would release the virus from the nasal passage, the nose and the throat, etc. And that release would then be able to spread to other people who are in other areas. At first, we were not sure if it was airborne, but then as time progressed, we found that there was such a thing called microdroplets, and that it could linger in the air for longer than we expected. So a normal virus that spreads by droplet infection would be like the flu virus. If you're near someone who has the flu and they cough and sneeze on you, or they cough and sneeze on something that you touch, then you could get it. But also if it's airborne, it could linger in the air. There was no evidence that it was spread during birth, and there was no hard evidence that it was spread by blood or from feces to the mouth. We at first were unsure of how long a person could transmit the virus to others, but I will go on to that in a little bit. What we do know is that the incubation period, meaning the time from exposure to someone who has the virus until the person presents with symptoms, was 2 to 14 days, okay? And if you had the virus, one thing that we quickly found out is that we didn't know how long having the virus would protect you from getting it. Like some viruses, like measles, if you get it, you will never get it again. But it didn't seem that if that was the case with SARS-CoV-2, and even more so now that there are different variants of the virus. So this is the virus we're talking about. And this is what we call molecular imaging. And this is a very, 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 very magnified picture of the virus, okay? And what is a virus? A virus is just a capsule of genetic material that is a foreign invader of the body. And when it invades the body, what it does is that it attaches to the cells of the body, and it enters those cells, makes copies of itself, and then infects other cells, okay? Those little red things that you see sticking off, that's the spike protein, and that's the protein that this virus uses to attach to the cells in the body. And it attaches first to the cells in the nose and the throat, and then to other cells in the body through this spike protein, which attaches to a particular receptor on those cells called the ACE inhibitor, the ACE receptor, okay? And that's on many, many different types of cells, but especially on cells in the lung. So that's the SARS virus, and that's how it looks. So what is an immune response? So as you can see there, my little green fellow, he is an invader. He is a virus, a bacteria, we have different types of invaders, but let's, for the sake of this conversation, just focus on viruses. So when a virus enters the cells, you have these other cells that you see there, eosinophils, macrophages, basophils. All these are types of white blood cells. And at first, you have, oh, it didn't come out, the innate immune response. And that means that as soon as it enters, these cells, which are in your nose and in your throat, start to try to kill the foreign invader. And also there are lots of molecules released. So if you can just think of when you get the flu, at first when you meet someone with the flu, you don't usually come down with it the same day. But a couple of days later, you start to get a little fever, a little sore throat, feel a little headachy. And that's because this innate immune response is occurring. And that causes the release of all these molecules that you see here. These are chemicals released by these cells. And what they do is that they're causing these cells to fight off this invader, okay? But it's not just about fighting off the invader locally. What happens then is some of these cells take a part of that invader and present them to these other cells that you see over here called T cells and B cells. And that creates what we call the adaptive immune response. And these T cells cause certain B cells to produce what we call antibodies. They also release other molecules that are involved in the immune response. And at first you get one type of antibodies called the IgM, and then finally you get what we call memory cells producing memory antibodies called IgG. And when these memory cells are activated, it means that whenever you encounter SARS-CoV-2, your body would, if you have an adaptive immune response, it means that whenever you encounter it, your cells would remember the encounter and produce what we call antibodies against it. And these antibodies neutralize the effects of the invader, okay? So I'm just putting this graphically, it's too detailed, so I just wanted to point out, because it just helps you to understand how vaccines work. And the first part is, you see, I'm using influenza here. The virus entering the cell in the first one, and then that's part one. And then the cell takes up the virus goes into the cell, the virus then releases its contents, and the blueprint of that virus, called the viral RNA, enters the nucleus of the cell. This is what happens naturally, okay? Enters the nucleus of your cell, where it makes copies of itself. It uses an enzyme to make copies of itself. And then once it makes copies of itself, it puts all of its proteins back together. It makes new virus, and that new virus then explodes from the cell, killing the cell that was infected and releasing new virus to infect new cells. So just the word virus, we know from like computer language, etc. It's something that's self-replicating, that's spreading all by itself within a system, okay? So that's what it's doing. Its own genetic material goes into your cells, uses your DNA and to make its own proteins, and then makes copies of itself and releases itself. And what happens is, how you overcome this reaction is by that adaptive and innate immune response, killing off those viral cells. So what are the phases of viral infection? First, you have what we call the asymptomatic stage. And in this is the, if you look at the bottom, it says days since infection. First, you don't have, this is a typical virus, you don't have any viral symptoms. So you're without symptoms, but you've contacted the virus. And then about day 5, the virus levels are rising. That's that blue line. The virus levels are rising and you start to get onset of symptoms. And then you go right up to the peak of the blue line, okay? And you start to get the peak of infection. So you're gonna get all the symptoms that I'm gonna tell you about shortly. And then at the peak, it starts to decline, and then gradually it disappears. But by about day 14, you're starting to produce your own innate viral response, and you don't become infective any longer. So that's why. And then you see the red line is your own antibodies starting to rise from about day 14 onwards, so that you are now temporarily protected against another infection with the SARS-CoV-2. So just think about when you get the flu. At first, you can start off by getting fever and chills, cough. And that's typical of all respiratory viruses. The difference with SARS-CoV-2 is how people progress, progressing onto a stage where they have shortness of breath or difficulty breathing. And this can happen very, very subtly with this virus. So people can not really feel that they have difficulty breathing, but their oxygen levels start to decrease and decrease. And that makes you tired, muscles achy, headache. And the thing that was unique here is this new loss of taste or smell, very characteristic of this virus, and sore throat, congestion or runny nose, nausea or vomiting. So you can see from this, it's non-specific. Lots of these symptoms occur in other viruses, just the regular flu virus. You might have some of these symptoms with if you have sinusitis, you can have some of these symptoms also if you have dengue. But the characteristic is the respiratory difficulties or the cough. Okay, so that is characteristic of a respiratory virus. Now, who is vulnerable to getting severe infection with COVID-19? So overall, 20% of cases are severe or critical. Now that is much higher than just the regular flu. I've heard people say this is just the regular flu and no. No, it's not. Because the regular flu has about 3 to 4% of cases that are severe or critical. We have about 20%, and that is a case fatality rate of over 3%, increasing in older age groups and in those with underlying conditions. So being over 60, being obese and having these conditions that I have here doesn't make you more susceptible to getting the virus. But if you should become infected with the virus, then you would be more susceptible to having severe disease, okay? So the other things that affect you, uncontrolled diabetes, chronic lung diseases such as asthma and COPD. If you're on immunosuppressive drug, your high blood pressure is not controlled, you have chronic kidney disease on dialysis, serious heart conditions, hepatic disease, blood disorders, those are the ones that are more susceptible to having severe COVID-19 disease. And that's what we want to prevent, because severe disease then requires intervention with oxygen and ventilators and so forth. So now I'm going to move on to vaccines. So what are the vaccine types that are available for SARS-CoV-19? And why are vaccines important? What vaccines are doing is that they are a way of giving you a small part of the virus itself without getting you infected by the virus. So that little small part of the virus that we want to give the person so that they mount an immune response is the spike protein, because that's the one that triggers the immune response. So we're going to give a spike protein or part of the spike protein or something that delivers the spike protein to you so that you develop that adaptive immune response and you start to produce antibodies. And that allows you, when you come into contact with the real virus, to produce those antibodies right away so that you don't develop severe disease. Okay, so right now, let's just talk about the 4 types or the 4 that are commonly available. And you have here the Pfizer, the Moderna, the Oxford AstraZeneca, and the Sputnik V. There have been a few others since then. We have Novavax and the Johnson & Johnson, which are different types of technologies as well. But these ones here are the most commonly used ones right now. And the Pfizer and Moderna gained lots of discussion because they're using an entirely new and different form of vaccination. And they're called the mRNA virus vaccines, okay? And these mRNA vaccines require 2 doses, and they are effective, and I'm just putting here how effective we are talking about, against developing severe disease, okay? Now, what is mRNA vaccines? mRNA vaccines take the mRNA, the code of the virus itself, and they put it into the body, and they cause you to develop the spike protein and release only that spike protein in your body so that you develop an immune response to it. If you remember, just a little ways back here, I showed you that, where was it? Right. I showed you that the virus does that in and of itself. The virus makes copies of itself. But instead of allowing the whole virus into your body to make copies of itself, which would cause you an infection, what we're doing is just introducing the mRNA code so that the spike protein alone is released from cells, and that spike protein alone then causes you to develop an immune response. The thing about this mRNA is that it's not stable. And so it has to be kept at very cold temperatures in lipid particles, so what we call nanoparticles of fats, okay? And that's why it has to be stored at -70 for Pfizer and -20 degrees. So you have to have very special refrigeration and so on. The Oxford AstraZeneca and the Sputnik vaccines are what we call viral vector vaccines. And I'll explain these in more detail. And these viral vector vaccines, they deliver the spike protein mRNA through using another virus. They use another virus to deliver the mRNA to your body so that you can develop a strong immune response. And at the time when I took this slide, the Oxford AstraZeneca strong immune response was not characterized. But now we know that that is about 73%, and that was in trials. But I will explain what that means in greater detail. These viral vectors can be stored at regular fridge temperature. So that's really good for places like Barbados and warm climates, because with the viral vector vaccines, we can maintain what we call the cold chain easier and deliver them to people easier. When you have fridges that require -70, etc., in this temperature, it becomes very difficult to maintain the cold chain. So let's talk about the specific vaccine. It was developed by Oxford University and AstraZeneca, which is a Swiss company, and it's manufactured for them by the Serum Institute of India. The Serum Institute of India is the largest vaccine manufacturer in the world. It's not an imitation vaccine that we got from India. It is the actual Oxford AstraZeneca company's vaccine that is made in the Serum Institute of India. As I said, it's a viral vector vaccine, and it uses a virus that delivers the spike protein genetic material, which is the antigen. The spike protein is the antigen. And that virus is an adenovirus, and it doesn't infect humans normally, but it can infect other primates. So primates would be, in this case, chimpanzees. Now, let me explain that all all living things have viral infections. So whether it is an animal or a plant or whatever, there are viruses to them. So what we're using is a virus that cannot infect humans, but it can infect other primates. And that is just a delivery mechanism for the spike protein genetic material. We give this adenovirus by intramuscular injection, and it causes the release of the mRNA genetic material for the SARS spike protein, and the immune system is activated so that those antibodies are produced through the B and T cells. Everyone says, why was this vaccine developed so quickly? Well, this new type of vaccine development technology was in progress over 10 years. For 10 years, Janssen was trialing, that's another drug company, was trialing this type of new mRNA type technologies in vaccine delivery. And so it is not that it was developed quickly, the technology was there. And they were also developing it for SARS, and SARS and SARS-CoV-2 were pretty close to each other. The Oxford Astrazeneca vaccine had clinical trials. That means you test it first on animals and then humans, with the final phase being tested in humans in 23,000 people in UK, Brazil, and South Africa, and then 40,000 people in USA, Argentina, Chile, Peru, and Colombia. So it was trialed on all different races, and so that we could see the effect. And they tried two different regimes, and they tried, giving it at 4 weeks, and they tried giving it at 8 to 12 weeks. And they found that the maximum immune response was with 2 doses, 8 to 12 weeks apart. But in order to report it, they reported the average of those two different regimes. And the average of those regimes said it presents severe disease in 73%. But since it's being rolled out now, we're finding that it presents up to 90% of severe disease in what we call efficacy or effectiveness studies. All vaccines are trialed so that we could see that there's no increased rate of adverse events. Adverse events are lasting effects on humans. So there's no increased rate of adverse events in people who had the vaccine as compared to the general population. So that's why we do phase 3 trials, to make sure that they are safe, right? And that's why the safety is checked for a long time by different bodies and approved. So there's no live virus in it. There's no human or there's no animal material in it. And there is no common allergens like milk or latex or that kind of thing. So it's impossible to get COVID-19 because it only contains the spike protein. So what do you get when you get the Oxford AstraZeneca vaccine? You have side effects. And why do we get side effects? Because it indicates that the immune system is working. These side effects last 24 to 72 hours. They can include arm pain, chills, fever, joint pain, muscle pain, fatigue, headache, diarrhea, or nausea. So like a very, very, very mild form of having the actual viral infection. And this lasts for a temporary time, 24 to 72 hours. And people who are accustomed to taking the flu vaccine know that this happens in getting the flu vaccine also. So you've heard a lot about herd immunity. And why do we want to vaccinate a population? So we want the population to be immune to an infectious disease so that those who take the vaccine also provide indirect protection to those who are not immune to the disease. What does that mean? So if you have 80% of a population who are immune to the virus, 4 out of 5 people who encounter someone with the disease won't get sick. Now, in this SARS-CoV-2, it's a little different because we can still transmit the virus even though you've had it, but the transmission is way less. And it's way less when you have the vaccine because you don't develop symptomatic disease. So you don't cough or sneeze or deliver droplet infection. And there's little airborne infection. So that's how it decreases the viral transmission. And Oxford AstraZeneca has been shown to decrease the transmission by about 67%. So usually about 50 to 90% of a population needs to have a vaccination in order to achieve herd immunity. So most vaccines, we aim for about 60%, 60 to 70%. And then the rest of the population does not develop it because you have stopped the spread of the disease in this amount of people. What happens if we do nothing? So if we do nothing, we don't take any vaccine and everyone just, just goes about their business. First of all, we're seeing it now. First, we had a primary surge, and now we're in a secondary surge of COVID-19. You run the risk with 20% of people having severe disease of overwhelming the healthcare system. So that means that everybody with other illnesses as well have impact on their access and delivery of care. And then you have excess deaths due to COVID-19. So you have more people dying from it, but also from not being able to access care. You got impact on healthcare workers. They may lack protective equipment. They need to be screened. And also they have a mental health impact of people working with a highly contagious disease. There's a possible increase of what we call non-communicable diseases and also sexually transmitted infections because all the resources are taken away from treating these. And also we can see that there is a social increase in mental health issues as well. So if we did nothing and we said, oh, we'll just leave it and let people, we have the risk of not being able to develop or to deliver healthcare system to most people. So I'll stop here. And I know that there'll be a lot of different questions and I will try to answer them as best as I can. But that's an overview of COVID-19 and vaccines.
Thank you so much, Lynda, for that overview of the COVID-19 infection itself and the way vaccines work. And certainly that is the appropriate platform for us to start with our questions. And again, we want to say thank you for those persons who have sent in questions. So let's get started. First question we have here. Hi, good evening. My question is, how would the vaccine or COVID for that matter affect a person that has sickle cell and this person has SC and has no spleen?
Okay, so sickle cell disease and SC with what we call hypersplenism means that normal production of white cells is impaired because white cells are produced not only from the bone marrow, but also from the spleen. So a person with sickle cell disease has a high risk, or with hypersplenism, which is the absence of a spleen, with SC or SS, sickle cell disease, has a high risk of having severe COVID-19 if they come into contact with it. The vaccine, remember, as I said, does not cause infection. It does not cause COVID-19 infection. But what it helps your body to do is to develop that adaptive immune response. Now, if you're immunosuppressed, which is what a person without a spleen or people who are on particular medications, like some types of cancer medications or immune suppressing medications, if you're immunosuppressed, it doesn't mean that you will have any more side effects or anything like that from the vaccine. What it means is that optimal efficacy, that optimal response to the vaccine will be less than in people who have an intact immune system. So the vaccine doesn't cause you harm, but you may not get as much protection as a person who has not taken the vaccine. And that's why it's really important for everyone, not just those who have immunosuppression, to continue to follow the health guidelines of wearing masks, sanitization, and social distancing, even after wearing the vaccine, because there are people like this in society who need to be protected.
Yeah, I want to reiterate that point that it's not a free for all once you've received the vaccine. Once you've gotten that shot or even the second dose, which you said would be 8 to 12 weeks after that, we can throw masks away and go back to gay abandon. Certainly we cannot because there are others in society that we must protect. And so can we, Lynda, put in that category with persons who have sickle cell and no spleen, those persons who are taking steroids, drugs to suppress the immune system, those people who might be having chemotherapy, would they
Right.
all fall under that category?
Right. So all of them fall under the category of immunosuppressed. And once you're immunosuppressed, the way it was said to me is your chances of severe COVID-19, should you encounter it, are high. The vaccine may not give you the optimal response, but it will give you a better protection than if you didn't take it, right? So you will get better protection than if you didn't take it because the chances of severe COVID in these people is high.
Earlier on your slide, you had gone over what some of the adverse effects of the COVID-19
No.
vaccine are.
The side effects, that's a different
Side
thing.
effects, yes, because
Yes,
adverse effects last a long
long lasting.
right. Please, just for some of our listeners, just go over the side effects of the vaccine again, if you don't mind.
So the main thing, sore arm. I got my vaccine yesterday. And I certainly have a sore arm. Okay. Yeah. So, and Dr. Boyce also had her vaccine yesterday. Yeah. So we are both experiencing these as we speak to you today. Okay. So sore arm, fever, joint pains, muscle pain, a headache, sometimes nausea, a little bit of diarrhea. And so it feels as if what people have said to me is like if you have a mild dengue. You know what dengue feels like, right? Your back hurt, your head hurt, your eyes hurt, but it's very short-lived, so it doesn't last. So you get it; these things go away within 24 to 72 hours. And a side effect is something that you expect to happen. We expect it to happen because it shows that the immune system is working. An adverse effect is something you don't expect to happen. And that's why we have clinical trials for vaccines, to make sure that they're safe and they don't have adverse effects. So side effects are not a reason to not have a vaccine. Side effects are the indication that the vaccine is working. Now, some people get no side effects or very little side effects. It's all very individual. So I've had colleagues who they had nothing. Okay?
Absolutely nothing.
And what we have found is that the older you are, the less side effects you get. Now that makes sense, because as you're older, it takes longer for your immune system to rev up then to get the car going. So the side effects are less in the older persons and more in the younger persons whose immune system revs right away.
Somebody is wondering whether or not we can expect these similar side effects after the second vaccine. You've had the first one, you've gotten the side effects. It's the same medication that you're getting in the second vaccine as in the first vaccine. So can we expect the same side effects?
Right. So the reason for getting, so your question is what should be why do we give 2 doses? Okay. We give a dose, the first dose, and then we give what we call a booster. Now we would be all familiar with that concept because we would have had measles vaccine as a child, and then you would have had boosters later on. What does a booster do? A booster increases the amount of immune response by that adaptive immunity. So if you have a booster of this, you get another immune response again. Okay, so yes, you will get the same side effects when you have the second dose, and that again indicates that you have encountered the same thing twice. But that's what we want, because when you encounter COVID-19, we want it to be able to overwhelm the COVID-19 when it comes into the body with those antibodies so that you don't get sick.
Yes, so one of the problems, Lynda, that we have been having with this vaccine rollout is the skepticism. Persons have been saying, it's coming from India. And well, you mentioned in your initial presentation that it has come from one of the largest vaccine production sites in India. And India is actually one of the vaccine capitals of the world. Many of the vaccines are produced in India. But some person is asking whether or not we are testing the vaccines that we've gotten here to make sure that in truth and in fact we're not getting water as opposed to getting the true vaccine.
Okay, so 60% of our vaccines in Barbados are made in the same place, Serum Institute of India. If you step on a rusty nail tomorrow and you come to my office, Renee's office, a polyclinic, whatever, to get a tetanus vaccine, there is an extremely high probability that that tetanus vaccine was made in the same place as this Astrazeneca vaccine. Okay, so let me start by saying that. What we are looking at now is to measure not only what the side effect profile looks like in our country, okay, but we also need to measure how effective the vaccine is in the country. So we're looking and planning what we call a vaccine efficacy study, which will sample the population and see how effective is this vaccine in our population? We know from other Black populations that it does work, etc., and that it is effective against what I would say the original variant of COVID-19, okay, which we had most of last year, and the UK variant, which is also now here. What you would have heard in the news is that it's not so effective against the South African variant. To our knowledge, we don't have that as yet, but that's why we're setting up screening also to make sure that we don't get some of these other variants that are resistant to the vaccine. So we're getting studies rolled out to look at the efficacy, to look at the side effects here, and also to look at surveillance for different variants.
Recently, we've heard on the news that we've lost a 9-year-old child to COVID. And when we say that, we are saddened by each death from the first one we
Absolutely.
had back in 2020 to the last one that we've had. Our society really has grieved because of this. So somebody's wondering, why can't children be given vaccine? Why are we not giving children vaccine?
Okay, the simple reason is because the vaccine is not trialed in children. It's now being trialed in children. Okay, remember I said that the young people have very vigorous responses, and the younger you are, the more vigorous that response is. So the exact how much vaccine, the interval to give it, etc., is trialed in children. But here's the other thing about children. Children usually get a very mild COVID-19. So they're mostly asymptomatic. We discovered that really early in the disease, that unlike other types of viral illnesses, children are the least affected, okay? And that's because of their very vigorous immune response, okay? And so the children were able to spread the virus, but they weren't necessarily getting ill from the virus. But because they have a very vigorous immune response, they can have what we call multi-system inflammatory syndrome in children, or MISC. This is a new discovery, I should say, for COVID-19. Not that it hasn't been seen with other viruses, but from about middle last year, we realized that this was happening in children. And so the children were not showing the signs of the initial infection, but that very vigorous response led to what we call a cytokine storm later on in the child. And that led to a whole host of inflammatory proteins and so on being developed in the children later on. And that caused effect on the kidneys, the heart, and all the other areas of the body. And that's what this child had. So it develops almost four weeks after the initial infection. And so it's a late stage severe complication that is rare, thankfully. Most children do not develop this, but the vaccine is now being looked at for giving to children.
Okay, so we're trying to talk about the different theories and the different concerns that persons might have about the vaccine and reasons why persons might not want to take the particular vaccine. And one of the things, I'm sure that you might have seen the video by now, Lynda, where someone has definitely gone through in detail the leaflet from the Astrazeneca vaccine and the claim that the vaccine has matter from aborted babies. And actually recently, when I was doing some research, remember that the Catholic Church is very anti-abortion. And the Pope is actually saying that if it's ethical, that we can go ahead, even if the research was based on studies done from aborted fetuses. So the question is, do the vaccines contain aborted matter from aborted babies?
Okay, so I've prepared for this question. So the way that drugs are developed is that they use what we call immortal cell lines, okay? And immortal cell lines are what we call clones of cells. So the most common immortal cell line that is used in the development of drugs are what we call Hela cells. And Hela cells are named for the woman from whom they came. And you may have heard of her. Her name is Henrietta Lacks. She lived in the 1920s, and her cells were taken from a cancer that she had. And the reason that they were taken is because we found that these cells lived for a long time on their own. And so they were very easy to be cloned. And that allowed us to develop and test what happens in cells through these cells. Now, the cells that were taken from Henrietta Lacks are not Henrietta Lacks, okay? And as I said, it was in 1927 or 1920s. I don't remember the exact date. Could have been a little later than that. But it was a long time ago. But the cells are still alive and they're cloned. And that's what we test a lot of our drugs on. The HEK293 cells on which the multiplication of that adenovirus for the development of this AstraZeneca vaccine, these HEK293 cells were taken from aborted fetuses in 1973. So in 1973, they would have taken some of these cells. And we also use cell lines from placentas, even from live births now, okay, to develop these immortal cell lines. You're cloning these cells over and over and over again. And that's how most of our drugs and many of our vaccines and many of our drugs that we commonly take are trialed using these cell lines, okay? So you take a cell line from a fetus from 1973 and you clone it. And the reason that you're cloning it is to manufacture the adenovirus, or to not manufacture, but to allow the replication, the making of more of that adenovirus, so that you can have more of it in which you can put the nuclear material, the spike protein. Is the HEK293 inside the vaccine? No, it is not. Is animal matter in the vaccine? No, it is not. The virus that is grown on this cell line is in the vaccine. So there's no fetal material, there's no human material, there's no animal material in the vaccine. All that is in the vaccine is the virus, the adenovirus, and the mRNA spike protein and things that keep it stable, sugars and chemicals and stabilizers and so forth. And that's all that's in it. There's no fetal material in the vaccine. Sorry, I can't hear you, Renee. I'm not sure. Okay,
yeah,
thanks.
what happened is, unfortunately, I had to cough, so I had muted my mic. The side effects of the vaccine. But you answered another question that we had. Somebody was asking about the different constituents of the vaccine, so the sugars and other matters which would keep it stable. Somebody's asking if they can take the vaccine if they've had an abnormal ECG.
So let's talk a bit about conditions in which you take the vaccine, because I have lots of people calling my office, I'm sure calling you too, Renee, and saying, well, I had heart disease, I have high blood pressure, I have, bad circulation, can I take the vaccine? So the vaccine trials included people with a large spectrum of non-communicable diseases. And what we found, and from real life, because remember, we've rolled out this vaccine in almost 1 million plus people in the UK so far, is that there was no clinical condition, no non-communicable disease that the vaccine could not be given to, okay? Now, people most commonly ask me, I'm allergic to penicillin, I'm allergic to aspirin, I have allergies to these various things. Can I take the vaccine? Remember, I said it contains no common allergens. So no milk, no eggs, no shellfish, no latex, nothing like that, okay? What the importance of reporting your allergies is so that when it is given, you can be monitored. So we don't just give a vaccine and tell you, yeah, okay, go on your way, right? Because the vaccine, if it's going to cause an allergic reaction, that happens usually within the first 30 minutes. And that's the same as if you get a shot for the first time in my office. So if you come to the office and you're getting first time you're experiencing a particular antibiotic, for example, we give you and we monitor you. And why we're monitoring is to see if you have an immediate allergic reaction. And if you have an immediate allergic reaction, we can deal with that reaction. And we can treat that reaction on site. And so that's why the period of monitoring. So allergies are important to report that you have them, especially if you have multiple allergies, not just like one thing, but, or if you've had an adverse reaction to any kind of vaccine before, you should report that as well. But there's no condition necessarily in which we said this is contraindicated, meaning that person cannot take the vaccine. So yes, if you have high blood pressure, kidney disease, diabetes, the vaccine is actually for you to prevent you from getting severe COVID.
Right. Certainly, those persons who have any chronic disease, like persons who might have hypothyroidism, who might have had their thyroid removed and they're on medication, they would also fall into that category of persons that is recommended for them to take the vaccine.
Right.
Another person here is asking why is there this seeming reluctance to discuss any possible negative reactions to the vaccine? And certainly, I would have to disagree with this one because um, each time someone was talking about the vaccine, the discussion was the possible side effects of the vaccine. In this discussion tonight, we've listed the side effects of the vaccine. So I don't think that there is a reluctance to speak about the vaccine. What we do know in medicine is that there's nothing absolute in medicine. That is the one thing that we can guarantee you in medicine, that nothing is absolute. What we don't have on our side is time. We don't have years of study of the effects of the COVID 19 vaccine because the COVID 19 vaccine has not been around for years for us to study. What we do have on our hands, Lynda, is 40 times the population of Barbados that has already died. And I think that's a very sobering thought.
Yeah.
And each day we're hearing about someone else who has died. I believe Dr. Corey Ford, the head of our infectious diseases here in Barbados, he was on the TV just yesterday. And you could hear the grief in his voice as he was talking about the state of affairs with respect to COVID 19 in the country. And whilst it is not our role as doctors to shove theories down persons' throats and force persons to do what they don't want to do, our responsibility is to try to give them the best evidence that we can and help them to make the best decisions, which would end up protecting them, their families, and by and large, their country. Because
Yes.
you spoke about herd immunity there, and we know that there are certain sections in the society that will not take this vaccine. For example, certain religious groups are
Mhm.
completely against vaccines. So we know that there are several hundred people who are not going to take this vaccine. And those of us who do have the ability to take the vaccine and so on, perhaps we should. What we're advising you, and we're going to get back to the questions right now, but what we're advising you is if you have any questions, don't stay home. Get your advice from sites which are true sites, not from any old person off the internet. Get valid information from GIS or from World Health Organization, from PAHO, from
Or from
read the
discussing with your doctor.
I
You
was
know,
just about to
discussion.
say, pick up
Yeah.
the phone and call your doctor and ask. These are my concerns. Like a person here is asking about the rollout procedure. Somebody said that they were, initially they were told that it was supposed to be for the elderly persons and those persons above the age of 18 to 64 with chronic diseases. But when they went down to the polyclinic to get their vaccine, it was sheer bedlam down there. So let's talk about the rollout procedure.
Okay. So what I can say here is that we got a shipment of vaccines very suddenly. And so the rollout procedures are being managed by the Ministry of Health and Wellness. BAMP has called for the scheduling to be transparent so that everybody knows who's getting it in what order and so forth. The vaccines are in a multi-dose vial. So it's not like you have one little vaccine for each person in a little vial. They have 10 doses in each vial. And so you're trying to give at least 10 people that vaccine because you don't want any to go to waste, okay? The rollout has not been smooth, and I can say that without a shadow of a doubt. I've heard various things from various people, and all I can say is that although we're not involved directly in the rollout process, we are definitely, as doctors, advocating for a smoother and more equitable rollout, because it is concerning to me as well that elderly people and people who are shut in will not get this vaccine before younger people who are presenting to the clinic who may not even have a non-communicable disease. And so I think there's always there's groups who are looking at the process and trying to make it smoother, but I cannot say at this point that the rollout has been as smooth as we would have liked to have seen it, or as equitable as we would have liked to have seen it. And that's about all I can say on that.
Yeah, we understand the need for diplomacy. One of the things perhaps in the future that we should have, and somebody mentioned this, is maybe a drive-through system or a mobile clinic for those persons who are unable to get out, because certainly the elderly who are shut in are high on that list of vulnerable people. So that would be something to consider for those persons who can't get out.
Well, I'm told that the drive-through is supposed to happen in this weekend. I don't have any more details than that. And the mobile is already in operation. But whether or not they will get to all the people whom they need to get to in Barbados, I'm not sure. But those two things are already in train and in operation. Certainly the drive-through would be welcome.
Okay, in your presentation earlier, you had mentioned about a viral vector. Somebody's just asking for clarification on what is a viral vector.
So the viral vector, a vector means an agent that carries. Okay, so a viral vector means that you're using a virus, an existing virus, to carry a part of another virus to the cells. So you're using that existing virus, the adenovirus, to carry a part of the SARS-CoV-2 virus into the body so that the body develops an immune response to it. So the viral vector, the vector is another virus, okay? And so that's what a viral vector vaccine is. And the two of those on the market are the Sputnik and the Astrazeneca. There are also new technologies like the Novavax, in which they're just injecting this spike protein by itself. So they just developed spike protein and developed it in the lab, and identical to the SARS-CoV-2 spike protein, and they're just injecting the spike protein and allowing the body to develop immune response to that. And so there are different methods of getting that vaccine, that spike protein reaction that we want.
Okay, I'm going to read this question as is. Are there any COVID shield vaccines available that can be taken orally for folks with trypanophobia or needle phobia?
I think that would be a lot of Barbados, okay?
Yes, very needle phobic.
Yeah. The answer is no, because if you were to take it orally, okay, now there are vaccines that can be taken orally. So for example, the polio virus is, and that's because that polio virus is what we call an enterovirus. It infects the gut, and that's how it gets into the system. So if you get a polio virus and then you, what we call attenuate it, because it's what we call a live attenuated, and you put it into the gut, then it can be taken up through the gut and cause that immune response. But this is a respiratory virus, and if we were to put it into the gut acid and secretions, etc., would just kill the virus and would just kill the protein, because it's not absorbed through the gut. So unfortunately, it has to be given intramuscularly via a needle and injection. I will tell you honestly, that's the least of it, because I didn't even feel the needle, okay? Because the people who are giving it are very, 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 very skilled in giving that injection.
Yeah, I have to agree with you completely, Lynda. I've told people on many occasions that despite being a physician, I do not like needles. And as I was about to protest to the nurse about giving me a few minutes to get settled to get the vaccine, she's like, okay, we're finished. So the stick, like Lynda said, is the least of it. I think for those persons who will have side effects, the stick pales in comparison to the side effects that you might get. But that is not to say you should not take the vaccine. The side effects do not last forever.
Right.
So we've spoken about the different technologies in some of the vaccines, two of the vaccines using the mRNA technology, and we had discussed this earlier. So we're encouraging you, if you haven't heard that part of the discussion, you can always go back and take a look at the video again. But another thing that has been on the minds of many people is, can this vaccine affect your DNA?
Okay, so if you remember the slide that I showed with how the virus enters the cell, and what a virus is doing basically is using your proteins to make copies of itself. It doesn't go into your DNA. So the normal SARS-CoV-2 virus does not go into your DNA. It does not alter your DNA. It's just using your cell's machinery then. So it's almost like somebody breaking your house, okay, and start using your things, right? And then have children and release those children from your house, okay? So it's not altering you. It's just using your things. And so that's what the SARS-CoV-2 virus does in the wild, in the natural, okay? So what the vaccine is doing is it's introducing that bit of protein that allows the spike protein to be made. Not the whole virus, just the spike protein. And it's going in your house, your cells, and using your things to make a copy of just that one part, which we call the antigen, that will cause an antibody response. So it's not going into your DNA, it's not altering you. I've heard all kinds of things. Does it turn you into something, will you grow an extra hand or a limb or nothing of the sort. It's just overtaking your cells to produce the spike protein, which it releases from your cells. Your cells don't rupture and burst and be destroyed as it would with the virus. They just release the spike protein to create that adaptive immune response.
Okay, so this person is asking for some details that probably would come from the Ministry of Health. They're asking, we keep speaking about people with uncontrolled NCDs being at particular risk. They're asking if you can confirm whether those who died from the virus in Barbados with pre-existing conditions had out of control NCDs. Is it not possible that we need to say even those with well-managed conditions are at risk for severe COVID-19? And yes, we have been saying this, whether or not we've been saying ad infinitum that those persons who have chronic diseases are at greater risk. I think Dr. Adrian Lord's his analogy of standing on the edge of a cliff. Those persons, for example, with the chronic diseases, they're standing on the edge of that cliff. If you control your chronic diseases, you can step a little further back from the cliff, so that even if the wind of COVID blows, you're not going to get blown over the edge, and that risk is reduced even more by becoming vaccinated. You're offered some level of protection, and the chance of getting that severe illness is reduced.
Right.
You can add anything to that?
Well, I like that analogy. The thing with SARS-CoV-2, and I want everybody to bear this in mind. The reason it's a pandemic is because we all have no natural immunity to it. Anyone can get it. Now, you would have heard about asymptomatic cases, people who just get it mildly and who carry it, and now we know spread it to others, okay? But they are not severely affected. Whether or not you will be an asymptomatic case or a mild case, or whether or not you will be a severe case or end up on a ventilator, is something that has to do with your own immune system. If you have an uncontrolled NCD, then the risk of that immune system being affected by that uncontrolled non-communicable disease is greater. If you have a controlled NCD, as you said, you stepped back from the cliff a little. If it's well controlled, you would be in the same risk category as people who are a similar risk category as people who don't have NCDs. And so it pulls you a little further back. If you have no NCDs, then yes, you can still get severe COVID-19, but you're further back from the edge of the cliff. Everyone can get severe disease. But who gets it and who gets it first is determined by how well controlled they are. Now, the question was whether or not we know whether these people were uncontrolled or not. Usually, if they're presenting and they're ill, we can't really, unless we have their history from their doctors, we wouldn't really know what their control was like before they presented. Okay? But what I will say is that almost 70% of the people who have severe COVID-19 or died in Barbados had an NCD. Okay? Whether it was asthma, whether it was hypertension, diabetes was probably the commonest one. And so most people have had an NCD who were severely ill.
Okay, somebody is asking just for a bit of clarification. We had spoken earlier, Lynda, about the second dose of the vaccine being the same medication. This person just wants to clarify whether or not the effects are going to be the same, and if it's or whether or not it's going to have its own side effects. So whether or not you can expect to get the same things like the arm pain, fever, chills, or
it's the same. Yeah, it's the same. It's the same vaccine. You get the same side effects. In some places, they have noted that with some of the vaccines, I can't really say with Astrazeneca, but with some of the vaccines, for example, Pfizer, when they gave the second dose, you could get a more vigorous response. Some people got no symptoms with the first, and they only got with the second. And similarly, that makes sense because now you're having a stronger immune response. So, but remember, side effects are temporary, right? They will pass. COVID may not pass. Okay. So yes, you could roll a dice and say, well, I'm not going to be one of the ones who gets severe disease. I know that I'm going to be an asymptomatic person. I know that I'm not going to have any severe disease. But the truth is, you don't know. And it's only the grace of God that is keeping us all as a country every day.
I go back to that interview with Dr. Corey Ford yesterday, and he was talking about the asymptomatic patients. He was having a discussion with one of the patients who was asymptomatic, and they were very upset that they had to be kept in isolation. In isolation, and he said within 24 hours that person was on a ventilator.
Yeah, so, and he has relayed instances where, I remember I said that what it does, unlike other viruses, it creates little clots called microemboli. Okay, this is what is unusual about SARS-CoV-2. And those microemboli lodge in the lungs, and they gradually decrease the amount of oxygen. So a person can be just with a mild cough and sore throat and talking today in the morning, and by evening, that oxygen level plummeted, and they ended up needing to have ventilation. And so that's what is strange, unique, different, and severe about this virus. Unlike influenza viruses and other common respiratory viruses.
And the same discussion on the small clots in the blood vessels in the lungs, the same thing happens in the hearts. We were having a discussion with Dr. Scanterbury, cardiologist, and she was saying that when they did investigations with persons who were coming in with symptoms of a heart attack and they checked the large vessels, there weren't any clots, but they discovered that with COVID, the clots seem to be in the smaller blood vessels going to the heart. And yes, the definite answer is that COVID-19 does have its own effects on the heart.
Right.
Our next question here is about logistics. If you get the first vaccine but not the second due to lack of vaccine on the island, so this is a case of supply and demand here, what's going to happen to you?
Okay, so what we found so far is that just from the first dose, 3 weeks later, you've got 76% efficacy. 76%. That's the real life trials on the UK. You have 76% efficacy just from the first dose. You have up to 12 weeks to get the second dose. Okay, so at 12 weeks, if you get, that's 3 months, and 3 months in COVID is a very long time. Okay, So we have up to 3 months to get the second dose. If we went past this, the 3 months, does that mean that all of the efficacy from the first dose has gone away? No, it does not. If we got it at 3.5 months, at 4 months, we would still give the second dose. Or if you missed getting your second dose, we would still give the booster of the second dose to boost your chances of having a greater immune response. But the peak efficacy is if you get those 2 doses at a delayed interval, 8 to 12 weeks. So currently, right now, we are giving 10-week interval. So that's what we're doing right now in Barbados.
Okay, so I've had personally to my WhatsApp, as well as forwarded in our questions for tonight, somebody is asking whether or not the COVID-19 vaccine, not the vaccine, yes. Let me make sure that I get it correct. If it's COVID-19 or the vaccine that causes impotence, I want to be correct. So just let me just be sure whether they're checking to see if it's the virus or the vaccine that leads to impotence. And it is the virus. The virus. Does COVID-19 cause impotence?
Okay, well, one thing we have learned with COVID-19, the virus, is that it affects lots of small blood vessels. So it affects the toes. We've heard something called COVID toes. It affects the heart, as Renee alluded to. It affects the blood vessels in the lungs. It affects kidneys. And over the time, each of our specialists in each of these areas, we have been meeting as doctors to hear from them all of the science and the research on each individual organ system in which these specialties exist. I have not personally come across impotence as a side effect of COVID-19. Having said that, theoretically, because of how the virus is acting and how it acts on small blood vessels, I imagine that that could happen. But whether or not I'm going to say to men, go quick and get the vaccine, because if you don't get it, you're going to end up with impotence. I ain't going to say that. I can say go and get it because it may save your life and literally the life of your family members by decreasing your ability to transmit it to them. So yes, theoretically.
So by extension then, somebody else is asking, does the vaccine lead to impotence?
Well, if the vaccine led to impotence, that would be an adverse effect. Remember, I said that vaccines are trialed for adverse effects. In the Oxford Astrazeneca phase 3 trials, there was a patient who developed a form of paralysis called transverse myelitis. Okay? And first of all, when you have something happen in any person who is in the trial, the first thing you want to say is this due to the vaccine or did this person develop it on their own? It had nothing to do with the vaccine. The first thing that happened is when you have an adverse event in every trial, you stop the trial. You stop it altogether. And then you look at that person, whether the background, if you can cause what we call an attributable risk to the vaccine, or if it is due to something outside. So that vaccine trial stopped that adverse event, stopped the entire trial while they worked out whether or not it was. And in order for it to continue, it continued because they showed that the transverse myelitis was not due to the vaccine itself. Any adverse event, certainly impotence, would cause cessation of the trial,
yes.
of any trial, okay? Because we would consider that unsafe. And I've heard a lot of people say, well, they're giving it to us to test it out on us. They don't want Black people to reproduce and all these kind of things. I've heard these things, but I want to say to you, that's not how the science is applied, okay? And we have to be very careful about what we listen to. One of the things about this epidemic is that it's also an infodemic. And there's lots and lots of material on the internet. There's lots of people claiming to be authorities and people claim, but we have to be careful. And we have to be careful, particularly as Christians, what we listen to and understand that there are lots of groups behind these things that promote false theories. And we have to be careful and ask God for wisdom in discerning whether or not the material you are reading is true or not. And if you don't know, forward it to someone who can help you. One of my patients forwarded a video the other day, and she said to me, "It's true, yes or no?" right? And I just replied to her and I said, this is why it isn't true. And she said, okay, thank you. So just double check, cross check, some of the things that you're seeing, because this infodemic, I fear, is one of the greatest attack, even more than the virus.
Tragedy.
Right? It is the greatest attack, even more than the virus. It's an attack on the way that we reason, on the way that we understand, and the way that we discern what is true from what is not.
When children are going to get their vaccines, many parents are a little concerned if the child has a little cold and so on, that they shouldn't take the vaccine. And many times they have to be reassured that a mild respiratory illness is not a contraindication for routine vaccines.
Right.
Some person is asking here, if you have a chesty postnasal cough, can you still take the vaccine?
So yes, just like you said with children, yes, you can take the vaccine if you do not have the symptoms that we are convinced that this may be COVID-19.
Exactly.
If we think it is COVID-19, we would recommend that you get tested first and then take the vaccine. Now, that brings up another thing that we didn't mention, Renee, and that is, if you have had COVID-19, should you still be getting the vaccine? Okay? And the answer to that, strangely, is yes. And the reason it is yes is because what they noticed with COVID-19, like influenza virus, the immunity is not eternal. It's not long lasting. Right. It's not like measles or polio or whatever. This is what we have called waning immunity over time. So between 3 and 6 months, the actual wild virus that you get infected with, if you met someone and contracted COVID-19, your innate immunity to that wanes over time. So we would give the COVID-19 vaccine to someone who has had it after they have had it. So between 4 to 6 weeks after, we would actually boost their innate immunity with a dose of the vaccine as well.
Okay,
sorry, I said that wrong. We would boost their adaptive immunity that they developed from their experience with the virus with a booster of the vaccine as well. Yes.
Okay, just for clarity, say it over again.
Okay, so if you've had COVID-19, the immunity doesn't last forever. And so what they have discovered is that by giving a dose of the vaccine after you've had COVID and after you've recovered and after it's completely out of your system, boosts that adaptive response that you naturally developed to a higher level so that you cannot get reinfection. Now you're saying, well, how could I get reinfection? Well, this is one of the things that has happened with COVID-19 and also with different strains. And that's what we're looking at now. If you've had one strain, can you get with different variants? Sorry, if you've had one variant, is it possible to get reinfected with another variant? It is early days for these kinds of things. We don't know all of the answers in terms of the long-lasting effects of COVID. And if the other thing is, we focus a lot on the deaths and the deaths and the deaths from COVID, and this people died. But there is also something called long COVID syndrome, and that is occurring even in people who had asymptomatic disease. What they develop is a late onset, strong immune response. And that can then lead to different signs in different organs of the body, usually chronic fatigue and sometimes neurological effects, headaches and weakness in the limbs. Long COVID syndrome is what we call morbidity from COVID. So not mortality where you die, but you can also get long-term effects from the disease itself.
Okay, so another question we have here, the COVID-19 vaccine is a vaccine, it's not a cure. So it's not given to those persons who are actively infected with COVID-19. But let's talk about those persons who are asymptomatic. So you have no clue that you are positive for COVID-19, but you've signed up because you have hypertension and you've signed up for your vaccine. Is there anything that you should be worried about in that case?
No. So if you're asymptomatic, unless you were a primary contact of someone who, so if you're a primary contact, you should have been tested anyway. Okay,
Anyway.
so right, so if you're a primary contact, you know that someone who works closely with you or is in your household has COVID-19, you should be tested anyway. And if you're a primary contact, you should be awaiting the test results before you go to get vaccinated. But if you didn't know, and if you were asymptomatic and you got a dose of the vaccine, you're asymptomatic means that your immune system is working. We give you a dose of the vaccine. You probably get the side effects of the vaccine just like everyone else, but it wouldn't cause you to, it would prevent you from getting severe disease, but the vaccine would not get rid of the fact that you are infected with COVID-19. You'd still be able to spread it.
Okay, this is a question. Somebody's asking, why are the nurses not wearing gloves when given the vaccine?
Okay, so that question came up a lot, and I found it a little surprising because in our public health nurses here, if many parents can recall, when they give vaccines even to children, they don't wear gloves. They've never worn gloves. They've always sanitized between patients and given that vaccine. They don't actually touch the site where the vaccine is given. They clean that site. They pull up the needle in a sterile manner. They just, maybe sometimes if you are thin, they push that muscle together and they inject it directly into the muscle without touching anything around it, and then put the swab on it. Yes, they could be wearing gloves, but then even if you wore gloves, you'd either have to take off the gloves between each patient, right? Which is also a risk, okay? And, or you would have to sanitize the gloves between each patient, which is really not much different from sanitizing the hands between each patient, which is what they do. So it isn't, our system has never given required that our nurses wear gloves for giving vaccines between each person. But we do, if you go to the clinic, you will see large bottles, you will see them sanitizing intensely between patients. So there's no risk of you getting infected from the nurse then, if that's the concern.
Yeah, certainly. I think that's where the concern is coming from, whether or not you can have any disease being transmitted. But you've explained what that what that has been. We have just a few more minutes, Dr. Williams, so we'll wind up the questions in just a bit, and then we'll ask you to just share your final thoughts, share your heart with us about the current pandemic and what you hope we as individuals can do. So I'm just going to go through the questions, making sure that I've gone through all the questions that have been posted. And again, for those persons who are asking questions that you might not have heard your specific question being answered, we would have addressed some of these issues earlier in the discussion. So please go back and take a look at the video. Somebody's asking about taking a different brand of the vaccine. So say, for example, we have the AstraZeneca now, and then maybe the second one we get is not AstraZeneca. What difficulties will that pose?
Yeah, so they're looking at that in other countries. Can you mix vaccines? No, that's the short answer right now. So if we've gotten AstraZeneca, we would have to aim to get back AstraZeneca to be given again. If we happen to get some Pfizer vaccine, then we would have to follow up with Pfizer vaccine. Now, I just want to explain to everybody that the way vaccines have been distributed to countries has not been equitable worldwide. So there are poorer countries in the world where there's not even one single person has received the vaccine today. Okay, and then the richer countries have vaccinated a third of their population already, and they've bought out millions of doses to vaccinate their entire populations, while other countries have none. To prevent this situation, the World Health Organization developed a vaccine facility called COVAX, which it asked all countries to subscribe to. And all countries would have paid a deposit to receive vaccines from this vaccine facility, which would then be fairly distributed according to population, how much you need. Well, I could say one thing about COVID. It has shown the selfishness of the heart of man, right? I say that COVID is the great revealer, okay? And what it has done is it's shown, lots of countries, they would have gone behind the COVAX facility and made their deals directly with the companies and, directly with the manufacturers and bought out their supply for years to come. So like Pfizer and Moderna, for example, their supplies have been bought out by most of the developed countries, okay? And so will we get any? It's not like we have, okay, we can get this, we can get that, we can pick and choose, etc. It's not been like that. There's a whole set of vaccine diplomacy going on behind the scenes. And even having received this amount that we've gotten, as you can see, it was a gift that we received graciously from the government of India directly to Barbados. But we don't have that ability to pick and choose like the richer countries do, who can say, well, I'll buy some of this and some of that. And, then let's see, what we're doing later on and what our availability is. We've got an Astrazeneca. It's a good vaccine for distribution in our society because it's stable and it can be kept at fridge temperatures, etc. And our goal is to get AstraZeneca again, to continue to give it to our population.
Okay, I want you to do me a favor, Lynda, and there are two areas that we're going to go over. We've dealt with these areas before, but I sense that this is still something that many people are having an issue with. So the two things I want you to go over, firstly, let's talk about those contraindications to the vaccine. People are asking about allergies to aspirin, Voltarin, centipede bites, ant bites. I know that we've dealt with this before, but let's just clarify for those persons who might not have been on earlier whether or not these things are contraindications to taking the vaccine.
Okay, so simple answer, no. Okay, there are no conditions, there's no disease condition which is absolutely contraindicated. There are obviously conditions in which you're going to take precautions. And people who have multiple allergies, not just, well, I had a rash to penicillin in 1973, okay? But there are people who have multiple allergies, who have to travel with what we call an EpiPen or an auto injector, right? That if they encounter something that they have an allergy, they have to give themselves an injection immediately to prevent what we call anaphylaxis. That's swelling of the face and the mouth and the throat and so on, okay? So those people who have multiple allergies should declare that they have multiple allergies because extra precaution will be taken to them. If they have multiple allergies, then they will be given the vaccine in a safe environment where they can be observed after receiving the vaccine. And similarly, if they have a reaction, it can be treated immediately. And that is the only requirement that we have with Oxford AstraZeneca. So yes, if you have chronic conditions, it's actually the vaccine is for you to prevent you from getting severe COVID-19. And if you have allergies, all you need to do when you fill out the registration is to declare, or if you have multiple allergies, declare that you have multiple allergies so that the people given the vaccine would know to take additional precautions for you.
Yes, the persons who are viewing are trying to understand when you spoke about the research being done from aborted fetuses and those cells not being in the actual vaccine. So if you could just explain that first again, we'd appreciate that.
Okay, so I explained that the virus is a viral vector. A vector is something that carries, and the vector in this case is another virus called an adenovirus. It does not normally infect humans, but it has the potential to deliver that mRNA for the spike protein of the SARS-CoV-2 virus to our cells so that we can then manufacture the spike protein and develop an immune response to it on our cells, okay? So how do you manufacture a lot of this? So I need to make lots and lots and lots of vaccine in a short space of time. In order to make lots of vaccine, I need to have lots and lots and lots of this adenovirus. How am I going to get that adenovirus? I'm going to culture it, for want of a better word, on these clones of cells. And the clone cells are called HEK293. And those clone cells were taken from fetal cells way back in 1973. They have been cloned over and over and over and over and over and over again, and are used in the development of drugs all over the world, and especially of vaccines. Okay, there are other cells that we use. We even use cells from other animals. We use cells from other from other places, but we use these types of cells, what we call immortal cell lines, to reproduce the virus, the vector then. So the vector is reproduced in these cells. We take the vector, which is the virus, containing the spike protein, and then we take that and put it into the vaccine. So the aborted cells are not in the vaccine. Only the virus manufactured in these cells are in the vaccine. Is that clear? The cells are no human or animal material is in the vaccine. Only the virus that we are multiplying to contain the mRNA is in the vaccine.
And the other thing we should mention is that several drugs that are being used regularly are made from this method. Drugs used to treat hemophilia, drugs used to build your red cell count in those persons who are on dialysis or chemotherapy. So this is not a new technology at all. In terms of replicating the cells. It's not a new technology.
Right.
And again, someone is asking, how long will the immunity last? And I think we spoke to this when we said that it seems to be more like the flu vaccine, where the immunity is not lifelong.
Right. So if you think about the people who get influenza vaccine, the recommended interval is that you get it every year. And the reason for that is that we can actually predict the ways in which the influenza vaccine mutates over time. So epidemiologists and virologists and whatever come together every year, and they predict this is how the flu vaccine is going to change from year to year, and this is how we're going to make a new flu vaccine for that. And you go every year and you get your flu shot if you're accustomed to taking flu shots to prevent severe disease. Remember, the flu shot doesn't cause you to not get the flu, but just like COVID, it prevents you from getting pneumonia if you get the flu. Okay? So in the same way, we have found that this respiratory virus, SARS-CoV-2, does not have lifelong immunity. How long that adaptive immune response lasts in us right now, we don't know. We're investigating how often you would have to have an altered vaccine. If variants come up, we will have to alter the vaccines in order to deal with these variants. That's why it's really important to protect our population and to find out what variants are here and whether or not we need booster shots of a different type. So it may be that you've had the vaccine and you got your second shot, and at some point in the future, you may need a booster, whether that interval will be a year, 6 months, 2 years. That really right now is an unknown, but that's what we're investigating.
Okay, so our last question for this evening, again, is a question of logistics that is pointing out some concerns about equity. This person is an elderly person, and they have said, tongue in cheek, that their application seems to be lost in cyberspace somewhere. And they're still waiting for a date for the appointment for the vaccine, but they're going, and by driving by, they see many young people lining up for the vaccines and so on. So they're wondering, should I take the chance to go to these places where we've been told stay away from these places to go and get my vaccine? Any advice for these elderly persons?
Again, I'm not involved in the decision making about vaccine rollout. I can only say that as medical practitioners, we have advocated for this process to be transparent so that everybody can see when and where they are to go and who is to be vaccinated before whom. What actually happens on the ground is something that I think is very, I've heard of people going one place and being turned away and going another place and receiving the vaccine. So what I would say is that most of the clinics are not turning away the over 70s, but in the last few days, they seem to have said, well, come if you have an appointment. Come if you have an appointment on the day and time given to you. Why some people have been called for appointments and others haven't been called for appointments, I, again, do not know. What I can say is that some of the places that you go to will give it if you show up even without an appointment, particularly at the end of the day. But I can't say that that's a policy, because right now I'm a little confused
Puzzled.
about the policy, puzzled about policy myself. And I don't want to go too much into a policy discussion because I can't really answer those questions.
Yes, but I can say from personal experience, some of my patients would have called stating the same thing, that they made appointments and they hadn't heard anything. And then about 2 days later, they would call me back saying, oh, yes, I've been called for my vaccine and told to go such and such a place. So it appears as though eventually you will get that appointment. The system is not fail safe. We can't predict who is getting and when they're getting. Like Dr. Williams said, it's about policy, and we're not 100% sure what the policy is and what's going on in those areas. But you try your best to have a conversation with your doctor. I think that's the theme of COVID, the COVID vaccine, the COVID infection. Have a conversation with your doctor. This is where your primary care physician becomes ultimately important, because he or she is able to give you that sound advice, able to listen to your concerns about the vaccine and the different videos and so on that are going around. And we think about the video going around with the Governor General's vaccine, for example. What a tragedy that was. But certainly, I want to reiterate before you hand over to Dr. Williams for her final comments is that you take your advice from reasonable sources, not these things that are going on WhatsApp. And Lynda said it. You ask God for that wisdom so that when you are reading the material, that you judge it correctly. You don't accept necessarily what you're being told, but you ask God to help you to make a wise decision for you, yourself, and your family. So, in these last 2 minutes or so, Dr. Williams, what do you want our viewers, listeners to take away about the COVID-19 pandemic and about the AstraZeneca vaccine?
What I would say is every death from COVID-19, I have felt really deeply. Um, I think from the very beginning of the pandemic, we who are doctors, we knew what it could do. We knew what could happen here, because we also knew that Barbados doesn't have a lot of resources, doesn't have a lot of doctors in different specialties, doesn't have a lot of nurses that can deal with ICU care. And you can have all the beds and the ventilators and whatever in the world that you want. It takes humans, it takes people who have families, who have loved ones, who have to make sacrifices to run them. And we knew that our healthcare system would be stretched. We knew that the non-communicable diseases would suffer. We knew that the antenatal patients would get pushed back. We knew that this would affect our private clinics and all the different parts. And so we advocated very strongly for trying to keep, as much as we could, the disease out. That's the past. We're in a different place today. And it is God's grace that we have done as well as we have thus far. What I would say to everyone is it's really important to do those basic public health things. Wearing a mask, keeping away from crowds, you know, keeping a social distance from people, not mixing between households freely, sanitizing your hands. You know, all of these principles are Bible principles. They're not new. God told the Israelites to do these things. They're in Leviticus, okay? These are not new principles for managing infection. But by doing that alone, we can manage a great deal of the infection. The problem is that everybody doesn't listen and everybody doesn't follow the rules, and there will still be people who are breaking the rules. I heard Mr. Chapman say that in one day he had 96 people who had breached the COVID-19 protocols, right? And everyone says, well, I'm just going here, I'm just going there, I'm just doing this, I'm just doing that, I'm just. But without realizing that your just could infect or affect other people. So please, please, let's stay at home as much as we possibly can. Eat the food that you have in the house. Make bakes if you don't have bread. You understand? And be content with what we have. Okay? And learn through this experience what God is saying to each of us. The other thing that I want to say is that vaccines are not perfect, right? There's no vaccine that is perfect. But if we have anything that we have in our toolbox that can reduce the course or alter the course of this disease in Barbados and change the rates of transmission, you know, to use Beijing parlance, let's take it, no? Right? Let's try to alter the transmission. It's not about trying to control you or somebody putting a microchip in your brain. And, you know, I've heard a lot of different things. But what I will say is, you know, we can live in fear or we can live by facts. And we can pray to God and ask Him to give us the wisdom about what to do in our individual circumstances. I'm not here to force anybody to go against their convictions or beliefs, but I'm asking you to prayerfully consider what is best for you, your family, and the country.
Dr. Williams, I really want to thank you for taking the time out. I know that you are feeling under the weather, so we will let you jump back into bed.
Oh yes.
in just a few minutes. In just a few minutes. But thank you to you for taking the time out to come to explain about the vaccine and to make things a little clearer. And we wish you a speedy recovery so that you can get back to doing all those things necessary at this point in time.
24 to 48 hours, that's all.
Yes,
Same to you, Benny.
Yes, thank you very much. And at this time, we are going to turn over to the chairman of our General Assembly, Reverend Vasco Perry, for some closing comments.
Hi, Reverend Perry. Your mic is not unmuted. So start with you.
Thank you very much. Thank you very much. First of all, let me say thanks to everyone who has tuned in on the broadcast on YouTube. We've been monitoring it online, and we are indeed pleased with the amount of persons that have tuned in. So thank you so very much. I know for a fact that you have been blessed. I know for a fact that you have received information that you can take as we say in Barbados to the bank, because I know that these two ladies who have presented and shared with us are highly qualified. So let me say thanks to Dr. Lynda Williams. She is the president of the Barbados Association of Medical Practitioners, BAP. We really want to thank you. Your information was extensive and it was so well broadcast to us, and well, I felt as though I was in a medical class learning a whole lot. And believe you me, I've dreamed of that several times in my thing. So thank you, make me feel somewhat like a medical student. I'm not too sure I will pass, but your information was really, really extensive, clear, and you can walk away, even persons who may not have a medical knowledge, with knowing what you said and understanding what you said. And Dr. Renee Boyce, someone that I've seen growing up from very small, I want to say to you that you have done excellently in terms of your moderating and your knowledge combined with Dr. Williams made for a truly intriguing and effective discussion. So thank you for that as well. And I want to thank you ladies for allowing God to just be part of your lives, because that makes the difference. And the passion and the appeal and the care that we heard in your voice was astounding and really heartwarming. Thank you so very much. I also want to thank my friends and colleagues from other congregations and denominations. Bishop Selwyn Braffett, a good friend of mine. He's the Bishop of Pawi, Pentecostal Assemblies of the West Indies. Also Reverend Caswell Jemmett, another good friend of mine. He's pastor in the Western Lake Nazarene. Elder Miller from Darrell's Road Gospel Hall. Elder Miller, you may not know me, but my wife is from the Gospel Hall, so I know you all give a very strong foundation in teaching there. And Reverend Derek Ward, a very great person in terms of counselor and marriage minister. So thank you, Reverend Dr. Ward, for being with us from the Harvest Bible Chapel. And again, thanks to all of you who tune in, to your friends and to your family and all those who are listening. Thank you and good night. And please do your best to keep our country safe, follow the protocols. And of course, if you are in the age group like I am, let's really consider taking this vaccine and making our country better forward. God bless you. Back over to you.